in particular. Oh, the recording's in progress. Got it. In particular, by the National Institute of Minority Health Disparities and National Institute on Aging. I also want to acknowledge my wonderful team, because this kind of work does not happen without a team. And here are some of the members of my team who helped to collect the data and informed the results I'll be sharing with you today. I also want to share that much of the work I'll be presenting happened here in Minnesota, and a number of nursing homes have participated in this research here in Minnesota. So some of you, maybe if you're a nursing home administrator or a staff member, you may even recognize some of the folks in photos here. So what I'm hoping to do in the next 40 minutes or so is to identify how systemic racism as a driver for these racial disparities that we see impacts quality outcomes in long-term care. I want to share my own recent research on quality of life disparities. As I said, this work was funded by a 5-year grant from the National Institutes on Health, and it's just ended in April of this year. So this is one of the first talks to be able to disseminate this work, and also to hear from you and to share some of the research-based solutions in mechanisms that we could use to address these racial disparities. I am going to start by defining racism, and I know that it gets sometimes to be a challenging and a controversial topic, but really the more research we do, and I've been doing this work for the last 15 plus years, there is preponderance of evidence which identifies the existence of racial and ethnic disparities in long-term care. And now many scholars agree that the root cause of these disparities are based in racism. And when I think about racism, again, it's a very sometimes a value-laden term. I like to use the definition by Dr. Kamara Phyllis-Jones, a former president of American Public Health Association, who defined racism as a system of, quote, structuring opportunity and assigning value based on race that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and in the end, saps the strengths of the whole society through the waste of human resources. Racism could have negative consequences that are intentional or unintentional. It could operate on different levels, and really is a massive public health issue because of the harm that it brings for individuals and communities. Up until, I would say, 2020 with COVID, especially in the field of long-term care, we really did not talk or acknowledge the importance of racism until I think COVID really exacerbated the existing disparities that we saw in place. And we started having a lot more public conversations about, okay, what is the root cause of these disparities? And so I wanted to share with you that in April of this year, there was a landmark report that was issued by the National Academies of Science, Engineering, and Medicine. The acronym that's used is NASEM. And some of you might be familiar with it under the old title, the Institute of Medicine. And this report came out in April 2020, and it was titled The National Imperative to Improve Nursing Home Quality. This is the first such report, that's why I'm calling it as historic, since 1987. The last time that the Institute of Medicine dedicated its, put in a panel of national experts and dedicated its resources to nursing home care was in 1987. And now the next time is in 2022, they just renamed themselves. This report is, it has 600 pages, so it's a massive report. But what I think is so important in this report is that it acknowledges that nursing home care, as it's traditionally been done in US, must change, needs to change. And it also acknowledges the existence of these racial and ethnic disparities that are systemic in nature, with the root cause looking at these systems of racism that are structuring how people receive care in the US. I also, for full disclosure and a little bit for dissemination, you may be interested in hearing this. So when the report came out in April, I was one of the reviewers, external reviewers for the report. And I also was one of those folks who was saying, okay, it's great to have this 600-page report. As a person who's dedicated my life to studying long-term care, I am celebrating the fact that this report came out, but what's going to happen? Is there going to be any action actually? And so in last month, Hartford Foundation, which also helped fund this report, has funded a coalition, which is called Moving Forward Nursing Home Coalition, of 100 some national experts to work on implementing the recommendations of this report. The report has 7 main recommendations, and Each of the recommendations has a committee that's working with CMS and other agencies to implement it. And I'm very pleased to share that I'm a co-chair of the first committee that's focusing on person-centered quality and equity. And I'm happy to talk about it more if folks have questions. Here, what I put are screenshots of some of my recent work that's calling for addressing, racism across long-term services and supports, and looking at some mechanisms of how we can do it in terms of policies. And I'm happy to share all of these as resources. So when I talk about racism in long-term care, what evidence do I have to show that indeed there seem to be mechanisms that are supporting it? Well, it is important to note that long-term care is the most racially segregated aspect of healthcare. And this racial segregation happens in a variety of ways. I have seen it through my own research where, hospitals have partner facilities, and that they know that residents with certain characteristics might be clustered in those facilities. We also see that once people are in a nursing home, individuals who identify as Black, Indigenous, or come from other communities of color, so that's the acronym I'll use, BIPOC, Black, Indigenous, or persons of color, they receive worse quality of care compared to their white counterparts. And this is, patterns of this, we trace it over time, and the disparities are only increasing. We also know that many people from communities of color prefer to receive care in a community instead of nursing home, but there is decreased availability of high quality community options for them, long wait times for waivers, et cetera. And then of course, as already talked about, COVID has exacerbated many of the existing disparities, but also has been a bit of a silver lining to start these national conversations, because many of you on this call probably, this is the work you do, this is our world, but for the general public, many for the first time, sort of became aware of the need to reform long-term care and especially nursing home care in the US. What I'd like to transition now from this broader overview to sharing results of my own work, which focuses on quality of life, and I will define it in a second. But first, let me kind of set up the context for this. So I have been a faculty member here at the University of Minnesota since 2012, and I came to University of Minnesota. I guess University of Minnesota was my preferred choice. I was lucky to have interviews at a number of universities across the country. Why? Because Minnesota has been a pioneer in a nation when it comes to looking at quality of life for long-term care residents, especially nursing homes. I knew about the work that was happening in Minnesota. I knew about the partnership between DHS and researchers and our good relationships with providers, which is an example here today. And I wanted to be part of that community because I know that's how change can happen if we can bring people together. And so when I first started working with DHS, who has been a partner in my work, I said, I'm really interested in looking at analyses by race, ethnicity, because that's, a big area of passion for me. And the director of the Nursing and Facility Rates Division at that time, Bob Held, who has been a great, supporter and collaborator, he's retired since then. He said, you can, but you probably won't find anything because, there are so few people of color in Minnesota nursing homes. Well, what Bob was saying was true, but also not true, because we've been operating under this narrative that it's primarily white people who go to nursing homes because people from communities of color want to receive care, in communities. They're more likely to have intergenerational families. All of that is true, but also not true, because the landscape has really been changing. In fact, there's been a quite large demographic shift that sort of has gone unnoticed when it comes to the proportion of residents from communities of color in nursing homes. In fact, if you look at the data from 1998 to 2008, which is now quite old, we saw an increase of 54% of Hispanic older adults, 54% increase for Asian older adults, increase of about 11% for African-American older adults, and notice a decrease of 10% for white older adults, which some have called the white flight out of nursing homes. As white people have more resources, they're more likely to use assisted living and other options, which are more likely to be private pay. There was a recent paper that just came out about a month ago that has replicated these results for 2008 through 2017, and the results are the same. It was the decrease in the proportion of white residents even larger, and an increase in the proportion of Hispanic, Asian, and Black residents across the board. So our nursing homes are becoming more diverse. We have more people from communities of color in nursing homes than ever before. In fact, with this current rate, the proportion of BIPOC older adults is set to surpass that of proportion of white people relative to their proportion in the general population. Yet we know so little about quality of life for people from communities of color in nursing homes. And as I've shared already, there is a lot of research that focuses on quality of care. And quality of care, think about it as clinical measures of quality, bed sores, pressure ulcers, pain, all of these are really, really important. But as I heard when I was living in a long-term care facility, when residents told me, they said, yes, I am in senior living, I am in the CCRC, assisted living, nursing home, wherever they were, because I need some help. But ultimately, I need to have a reason to wake up tomorrow. And that means I need to have some motivation for knowing that I'll be treated with dignity and respect, that I still have relationships, that I have things to look forward to, as any of us would, right? We don't want to be reduced to the status of a patient. And I think that's what sometimes happens when we think about how quality measures are constructed for nursing homes. It's all about medical quality when people are whole beings. And so my work, after my experience of living in this facility, doing my master's and dissertation, focusing on that, has become committed to seeing how we can improve quality of life, which is a multidimensional kind of comprehensive measure of well-being beyond just clinical indicators of care. And so lots of research on quality of care, the clinical measures. It finds racial disparities in quality of care measures, in particular that BIPOC older adults, so people from communities of color, more likely to be placed and receive care in poorer performing nursing homes. So nursing homes that have fewer resources, primarily Medicaid, poor quality ratings, and in the end, report worse quality of care outcomes. We also know, as I noted, that there is racial and socioeconomic segregation of nursing homes in this country, much greater in some states than others, but certainly true in Minnesota as well. And so what I am sharing for you from my work, and I must say, I don't see anything in chat, but maybe Anne or Jay, please pause, just speak up if you need me to pause, or people have some clarifying questions, since I don't see chat. But what I want to do is I want to share results right here from Minnesota. We are leading the nation. I've been tapped to serve on a number of national committees because of the pioneering work that we are doing here in Minnesota. And one of those things is that Minnesota, since 2005, has been collecting residents' quality of life scores for residents in all of our Medicare, Medicaid certified nursing homes. So what happens, there is a survey firm, so an independent survey firm comes in and pulls a random sample of residents from each of these facilities and conducts in-person interviews with these residents. So for you to know, I am using these in-person interviews. We have about 13,000 interviews each year. And I'm using them from 2010 to 2015. I've also updated the results through 2018, and I'll tell you that the results are quite similar. And then what I do, I link these resident interviews about their quality of life. I link it to residents' clinical measures from the minimum data set. And what minimum data set is, some of you may know it, some may not. This is federally mandated data that nursing homes must collect on each new resident. They update it every quarter, that collects residents' clinical measures, as well as certain socio-demographics. And then I also link it to facility characteristics. So in the end, we have a quite unique data set of resident interviews for each year, linked to facility scores and linked to their MDS scores. And I can provide more detail on data sets if you have questions later. But this is just to give you context on where I'm drawing these results from. So using these data, and the results here are updated through 2017, we find that residents from communities of color, while they're becoming overrepresented in our nursing homes, actually have quite different needs than their white counterparts. They are up to 20 years younger. They are more likely to be male. They are more likely to have longer length of stay, meaning they are more likely to convert from post-acute care to long stay and stay there considerably longer. They have fewer impairments in activities of daily living and less likely to report cognitive impairment, but have higher prevalence of severe mental illness and behavioral symptoms. We also know that they live in different facilities. And what we found here is that in Minnesota, they're more likely to live in twin cities versus other locations. They're more likely to receive care in for-profit versus nonprofit facilities, larger versus small facilities, facilities that have much higher proportion of Medicaid per patient day, meaning fewer resources, facilities that have lower rates of staff retention, or maybe a different way to say it, higher rates of staff turnover, and facilities that just on average have fewer staff hours per resident day. So I think I know I'm going kind of quickly here, but think about the picture now in quality of life, right? I've shared the results on quality of care. Well, in quality of life, what we're seeing is that, okay, resident profiles have some important differences, right? Which mean probably different types of interventions needed to improve their quality of life. And also there are these structural pieces in terms of the facilities where they receive care, which right away have, and these differences are all significant, right away have implications for access to resources and staffing. So all in all, looking at data right here from Minnesota, I have found, starting in 2010, going all the way through 2018, that's the most recent data I had, was that we find significant and growing racial ethnic disparities in quality of life for especially Black and Indigenous residents. We didn't see differences for Asian and Hispanic residents compared to white residents. So Black and Indigenous residents had significantly lower scores on their quality of life measures. And as I noted, quality of life has sort of different domains or categories, if you may. And some of those categories include food satisfaction, which is super important, meaningful activities, so sort of social engagement and attention from staff with questions like, do staff know you and treat you as a person? And these were the domains that had the lowest scores for Black and Indigenous residents. So this is on an individual level. On a facility level, because we know that there are structural disparities, we found that white residents who live in primarily white nursing homes seem in general, pretty satisfied. But Black residents who live in primarily Black facilities that have higher proportion of residents from communities of color, because in Minnesota, we don't really have any primarily Black facilities, have the lowest scores, which really, again, is indicating the role of these facility characteristics. I know there are a lot of lines here, so don't worry about it too much, but I just wanted to show you something for those of you who really like to see your data and methods. I think it's important. So what you see three kind of charts, and you see the line, the solid blue line, that's the line for white residents who live in a primarily white facility, so 95% white facility. And the dotted red line on the bottom is for not white residents, residents from communities of color who live in the facility that is in the 75th percentile in Minnesota, because again, we are primarily white, of communities of color. So in Minnesota, it ends up being about 30% of their residents are from communities of color. So this is what you see. The blue line, white residents and predominantly white facility, the dotted red diamonds, people from communities of color in a facility that has about 30% residents of color. So for comparison, right away you see that the solid blue line, there's quite a big of a gap between the solid blue and the dotted red. The other lines are looking at residents who are white, who live in these facilities that have higher proportion of residents of color, and they do have lower scores as well in these facilities. And then the solid red line are for residents who are from communities of color who live in primarily white facilities. So what you see here are these are just their quality of life scores and the kind of facility where they live. Then remember, I told you that residents have different characteristics and different needs. So you might say, well, residents from communities of color, if they have these different socio-demographic characteristics, different diagnoses, that's why they report lower quality of life scores. So what I did, because I could do that with statistics, I can adjust for differences in diagnoses and these demographic characteristics. And the gap starts to shrink a little bit, but not so much. And then remember, I also have facility characteristics. So I put those in, size, location, profit, for-profit, not-for-profit status. And this is when it shrinks the most. But even then, you still see that the gap between the solid blue and the other lines persist, meaning that the residents who live in primarily white facilities report higher quality of life scores compared to residents who are white or BIPOC who live in primarily BIPOC facilities. Feel free to put your questions and comments if you have them for me in chat. I know I'm sharing a lot of information, but I like to disseminate these results. Again, this gets methodological, but I like to share these results so you could see where I'm getting them. So what I did here, I partnered up with an economist and we used econometrics methods, which allow you to do something that I think is really interesting, right? Like we see, let's say, look at food enjoyment, this one. There is a 12-point difference, which is meaningful and statistically significant between white residents and non-white residents in their satisfaction with food, meaning that residents from communities of color, are going to, and this is growing over time, are going to be less satisfied with food. And it's at least 12-point difference on a 100-point scale. And these are all pretty tightly clustered scores. So 12 points is big. So what we can do here, we can use these econometrics methods, and we could say, out of these 12-point difference, how much of that is due to all of these clinical characteristics that I have from the clinical data? I could put that in. How much of it is due to facility characteristics? And is any of it left unexplained? So this is what I'm doing here. The 12 points, the yellow on the bottom is due to resident characteristics. So out of 12 points, about 1.3 is due to these socio-demographic differences, gender, age, younger people will have different expectations, etc. Then this gray one is due to facility being what I'm calling high proportion BIPOC facility. So facility that has about a third of its residents from communities of color, which we know is a proxy for access to resources, etc. Then the biggest chunk here, the blue 4.5, is due to other facility characteristics. That's where staffing comes in, Medicaid payment, size, metro versus rural. But notice, so out of the 12 points, we can explain about 8 or 7 some, but about 5 points are left unexplained. And that's where I'm pointing to, what are these? We can only capture so much in our big data. Yes, I have a lot of data. I have access to claims, but we only see certain things through data. And that's why we need other methods of data collection, which I'll share with you in a minute, talking to real people. And what is it that's happening? And to me, these 5 points are things we can document that get at how racism operates, where people, how they're treated by other residents, how are they treated by staff, what are these other aspects of living in a facility that has an environment that is not conducive maybe to community participation, family participation. So these are sort of soft factors that matter quite a lot for each of these domains that we don't have in our data. And so what I did, because I am a social gerontologist and I believe in using variety of tools to answer our questions, in addition to these big data analyses, my team, and I showed you some members of my team, conducted ethnographic interviews. And what it means that they used methods that do interviews with residents, interviews with staff, and just observation, where they're just spending time in the facility observing, because that's a very important method of getting to know what's happening, in 6 high proportion BIPOC facilities in Minnesota. These facilities were all top numbers on a list of highest proportion of residents from communities of color. I'm very grateful to these facilities for their participation. Their names, of course, are confidential. And my team members spent at least 3 months doing what I'm calling participant observation, where everybody knows that we're from the University of Minnesota. We go through volunteer training. My team members help with activities. They're there basically every day, and they're there to help volunteer, get to know staff and residents so that they could also build better rapport for interviews. In the end, we have over 600 hours of participant observation, interviews with 96 residents and 61 staff. And we also did focus groups in each community where the nursing home was located, with family members of residents and sort of community leaders, community members. So we did 36, we have conversations with 36 focus group participants. I'm going to skip here, but basically the point of this, if you're interested and the recording will be posted, is for you to see how it is I'm approaching understanding these racial disparities. National Institutes of Health, which also has acknowledged, okay, we see racial disparities across many indicators, sort of helping researchers to think through different levels of influence. What happens on the individual level of influence? What happens on the interpersonal? What about community, and then broadly societal level? So what I will try to do, I'll try to get at the individual level, interpersonal, and community. Societal is sort of outside the scope of what I could share. And so quickly on the individual level of influence, I'll talk about resident relationships. And remember, these are the things that big data can't capture, right? But we can observe, we can get through interviews and focus groups. On the interpersonal and organizational factors, I'm going to talk about care from staff, opportunities for meaningful activities, culturally appropriate meals and food-related issues. And finally, on the community level of influence, the need for greater engagement with BIPOC volunteers and community organizations to improve quality of life for residents from communities of color. Okay. So the first theme, looking at the individual level of influence, we certainly saw quite a few instances of sort of resident to resident issues that they attributed to their race, ethnicity. So we saw segregation based on race, ethnicity, where some of it was voluntary segregation. People clustered with those who are from their racial ethnic group, and they were very intentional about doing so. Sometimes you almost see segregation on floors also of certain facilities, how, One floor is primarily Black residents, one is Asian. But here's an example from a Vietnamese resident who said, no, I talk to Vietnamese residents only because I don't know the language to communicate with people of other races, which, by the way, was another big finding for me, is that in the clinical MDS data, if I'm just looking at those data, I don't really see so many residents who are non-native English speakers. And maybe some of you here can share if you are filling out those forms. Certainly those are not like forms that are used for payment or maybe care planning in the same way. And so I'm assuming some of them are left unfilled because we met so many residents for whom English was not their native language. And of course, that is going to impact their quality of life, their ability to participate and engage with other residents. We did observe and we did hear quite a lot in interviews about use of racial slurs. This African-American resident said, I think there was one guy who wished to disturb here. He used to go like, oh, he insulted people who used racial slurs. But I also want to tell you that when it came to racial slurs, a big surprise for me was, at least when I was in the facility and my team members got it through observation, there were many more racial slurs towards staff that seemed to be openly used by residents than resident to resident racial slurs. So that was sort of a bit, I guess, I wasn't looking for that, but that's what we observed in these facilities. And then we saw, instances of aggression, tension. Some people said they felt that they were treated differently by other residents because they're a foreigner, and just a lot of sort of intrapersonal issues that they attributed to their racial ethnic group. And the second area of influence, I'm looking at the role of organizational factors. And I could talk quite a lot about this, but just for the sake of time, on the care from staff, this is where I heard a lot about racial concordance, where Black residents said, for example, that they felt that Black staff took better care of them. And you see a quote from this white resident who said, well, I've seen some of the Black aides will pay a little more attention to Black residents versus white residents. So there is this whole issue of racial concordance, similarity, and I'd love to hear from you on how you think, maybe your experiences and how you've seen it manifesting in care. This Hmong resident said they staff, and we did these interviews in Hmong Vietnamese as well, and then translated into English. We had staff members who are native speakers. They said they try to treat us good, but to say the people who can't speak English, they wait for the last minute and they take their people first. And this gets to the previous comment that for people who are not native English speakers or who hardly spoke any English, I really saw them as most vulnerable. And then, there are translation services and I saw how they were used differently, how sometimes staff were pulled to translate. And it was just a massive issue and a real issue that needs more attention and resources for these residents. Activities was a big one. As you saw on the previous charts, activities is one of the areas that has the largest racial ethnic disparities. And here, I'll give you a couple quotes where an African-American staff member said, I just don't think they've got a lot of Black things, that they would really like, speaking of residents from communities of color. Yet they've got a lot of white games here. And this is what I saw where in all of these facilities, and, mind you, for Minnesota, they're high proportion BIPOC, they all had white female staff who were super well-intentioned. I guess, no, not all, but male and female staff, but they were all white, and who were all well-intentioned. But also when I talked to them about programming, they talked about lack of training and resources and how to develop culturally sensitive programming. Family members, especially of Black residents with dementia, they had a lot of complaints about how programming wasn't culturally sensitive for their loved ones, the music, the activities, and how, and we did observe many residents just sort of sitting in front of TV and not being engaged, maybe because the activities were, of not of interest to them or the approach wasn't working. I'll read you this quote from African-American resident, and you kind of see why I thought it was illuminating of some of these themes. So the resident said, there is nothing to do. You play cards, you're back. Play cards, back. I wanted them to try to juice up the schedule, get a focus group together so we could have to choose, because you got younger people here. Remember, BIPOC residents on average 20 years younger and more likely to be men that don't want to just sit and play bingo with half of the folks who don't even know what's going on. And so I think activities is a large area for intervention, policy improvement, pay for performance, quality efforts, whatever we could do there to create and test a culturally sensitive programming for BIPOC residents in nursing homes. Food is a huge one. Food was the largest disparity. As somebody who spent 2 years living in a long-term care facility, I could see why food is so important. And this African-American resident said, well, it's just terrible. I mean, I fuss still about the food so much. It's not so much just the food, it's an hour late, it's 2 hours late. And then sometimes you got residents eating lunch at 2:30. So at 6 o'clock, no one's going to be up to eat because they're going to sleep. And this code really gets at the broad issue that most of the residents, white, non-white in these facilities, were not satisfied with the food service. But residents from communities of color then had additional complaints about food. Maybe somebody, they don't eat pork and the pork was served for them. Rice was a big issue, how for certain communities, Southeast Asian, rice is such a big part of their culture and their diet, and that wasn't available in a facility. Some residents talked about how they went hungry because they couldn't eat the food due to dietary restrictions. So many issues when it came to food. And then finally, getting at this issue of community organizations. This was probably honestly the biggest surprise for me. And I think this is where some of that unexplained disparity also gets in. Before this project, I have done a lot of work in primarily white facilities. And in most of these facilities, I saw a great degree of volunteer engagement. There were always some volunteers, there was family members coming in. And it was quite shocking for me when in half of these facilities, there were zero volunteers. I mean, zero. My team members were the first volunteers who went through training and were volunteers in the facility. And, volunteers do so much more than just direct kind of engagement with the residents. They create a culture of transparency and openness where it's okay for different people to come in and staff know that there will be other people there. It creates accountability. And the fact that there were facilities that had zero or very few volunteers, maybe like they have 2 people come in from a particular religious group, made it very difficult for residents to connect with members of the community, even though all these nursing homes, we also did these focus groups, they were all in zip codes that are high proportion minority zip codes. And so this one white staff member quote here, I'll show you, said any prospective volunteers, regardless of whether they're located, they would have to drive to get fingerprinted, talking about some of the barriers for volunteers too, like we had to do that. Okay, you have to get fingerprinted, you have to go through various forms, HIPAA, training. And the staff member said, I will say that has been probably the largest detriment I've had to finding volunteers who are willing to actually do it once they realize how the process works. So I think one of the areas here is, can we do anything about this process that is so onerous to bring people from community when we know how important that engagement is, especially for residents from communities of color who many of whom also don't have family members who visit them. So those community members may be the only folks they would see. And then this African-American staff member said, I don't know. When I asked about volunteers, I haven't seen anybody from the community here. So I couldn't answer that, which I probably might say, I seriously doubt that the community interacts with them, meaning residents from communities of color. And so what are some implications for the future? I know I have a lot of text here, but I'll kind of go through this to ensure we have time for discussion. I would argue that this work shows that there is a need for institutional and system level change. We must do better. We need to improve nursing home quality of life for everybody, but especially for people who are experiencing the biggest disparity. And in this case, people from communities of color. We see that there are structural disparities where facilities that have more resources tend to be primarily white facilities, and we see higher satisfaction among residents who live there, quality of life, quality of care, all of these measures of quality. And so I think here is where we really see evidence for the role of Medicaid and how we need to think about payment and how we reimburse care for nursing homes. What happens when a facility is 90% Medicaid? I mean, I've been in these facilities. My staff members, they talked about it smelled, it was dirty, there were holes in the ceiling. I mean, this is not what I expected to see in nursing homes in the US coming from me being an immigrant here. I think when it comes to policy change, and I do a lot of work with the Minnesota Department of Human Services, with CMS, I work with a number of national organizations. I really see opportunities for programs such as pay for performance and value-based purchasing. I can talk more about it if it's interest to you, how maybe those could be redesigned or targeted to improve and address these disparities. And really what I think we need to have incentives for nursing homes to want to do this. This is hard work. It requires resources. It's easy to say, oh, you just need to provide culturally sensitive care. But like these activities directors told me, if you don't receive the training and you're working all the time, how do you know how to do that? And so I think there need to be resources from the state and other organizations to provide support for nursing homes to do it. We certainly need to invest in quality of life initiatives for our residents from communities of color, especially also those who have limited English proficiency, because they are often truly left behind. And areas that need a lot of attention are activity programming, food, and this general area of staff relationships with residents, where residents really talked about that they felt that they were not being treated with dignity and respect. In that same token, I've seen with this observation work and introduced the importance of having staff from communities of color in leadership roles. What we often see, we see, white administration, and then we see, more CNAs and our direct care staff, being women, immigrants from communities of color. And I'll tell you, in a facility where I saw an African-American, director of nursing, African-American residents talked about how they trusted her, how they were, more adherent, how they felt she listened to them. So we need to create initiatives and opportunities for promotion and upward mobility for our staff from communities of color. And then finally, I can't emphasize this enough. We must build more community/long-term care partnerships. We can't make these nursing homes be like this isolated shell that doesn't have any interaction with its community, especially when this will be so important for residents who might not have anybody else who looks like them, comes from their cultural, racial, ethnic group, or family members who would visit them. So this is where I have some of my recent publications here, and I want to stop talking so I can hear from you. And that gives us about 20 minutes. I see there are some questions in chat. I know I went through it quickly, but I really want to have a chance to talk to you. So the first comment I see here is from, is it Jay? Okay, great, Jay. Thanks for the question. And the question was, do you find this in all aspects of BIPOC life situations, living in communities, schools? Do you mind giving me just a little bit more context, since I know I can call on you, Jay?
Yes, thank you so much. It is incredible, important work that you've done. The question came from in school, are we seeing the same set of data in satisfaction in a highly BIPOC school or a community of color versus an all-white school? Do you see the same data points? Would they overlay?
Thank you for that question. So first, what I could say, and I'm a researcher, so I can only speak from the data I have. Since I study long-term care, I don't have any data on schools, but even though I don't have these data, certainly I have seen other studies which report similar trends to schools. And I'll tell you that in publishing some of my papers, it's interesting you asked this question. Some of the reviewers asked this question too. They were saying, okay, maybe this is the first study that's documenting this in quality of life for BIPOC residents in nursing homes, but they asked me to make comparisons and parallels to other settings, and schools was one of the examples that was brought up. So I think it's a really good question, because sometimes, again, and that's what researchers do, we become highly specialized in one area, and we certainly need more work on equity and disparities in long-term care. I feel like relative to other areas, this field, most racially segregated of any healthcare settings, but it's just kind of been left, and as it has been relative to healthcare as a whole, reimbursement, all of the things, we can talk about it. So I feel that that's okay to focus, just on long-term care, but I certainly also think it shows the systemic nature of these disparities. Long-term care is just a microcosm of these larger societal disparities that unfortunately we see kind of over one's life, right? And I pick up people when they're older and when they're, in my data and when they're in a long-term care setting, but it's been a cumulative process. So it's a really good question, yeah. I can just kind of go through questions. You want me to read the questions, Jay, or how did you want to?
Please, yeah.
Yeah, I see a question. Please forgive me if I'm mispronouncing your name. Marceline Downer, and it says, it's great to see that you have quantified and documented all these disparities we see every day. Thank you. That's where econometrics comes in. I hope your research has been used to inform and make changes. Thank you so much. Honestly, that's what matters to me. And I think about, long-term care providers who honestly, that's kind of risky to allow me and my team to be there for at least 3 months, observing, interviewing, and I'm grateful to them for doing that. But I also think it shows that, again, I think we have a unique context in Minnesota where we could build these partnerships, and we want to, I think we're working overall toward the same goal, and that requires communication. I've done quite a lot of research in other states, in some other projects, in particular in Illinois. This was the most challenging state where when I went into facilities in Illinois, and I was in one facility, when I talk about high proportion BIPOC facilities in Minnesota, that's like 30% of residents. I was in South Chicago facility that was 100% African-American, all staff, all residents, and one white male administrator. So that's an interesting dynamic. But in this facility and other facilities, the folks were so surprised to hear about what we have in Minnesota. Like, wait, what, you collaborate with DHS and providers let you in, and then you get funded. So I am very grateful for the general kind of opportunity for collaboration. But to your point, Marceline, if we just document it, I publish these papers and, do these talks, in the end, what's the true impact? And I think the true impact has to come by engaging policymakers. I think Medicaid is a big area. And so that's why I provide a lot of service. I'm serving on this, big new national coalition. I encourage you all to check it out. I can put it in chat. This work just started. It's very public work. I am co-chairing this committee, and maybe you can tell me, you can raise your hand or whatever, if you're familiar with these groups, with CEOs of the Greenhouse and the Pioneer Network. So each committee is chaired by a sort of national researcher partnered up with somebody from provider community or other stakeholders. So in this case, these two groups, the Pioneer Network and Greenhouse, they're the two groups that have been really pushing for person-centered care, culture change in nursing homes for the last, since 1980s. And so, and as co-chairs, then we invited, and this is all public, I'll put it in chat, we invited 16 members nationally, geriatricians, researchers, older adults, that is very important to me, and staff to serve on the committee. And the goal is to inform CMS, we have CMS at the table, and really try to operationalize these recommendations. Like, what does it actually mean that Medicaid rates need to be changed? So that's the work I'm doing. I'm very interested in, engagement, hearing from you all as Minnesota stakeholders. I'll put it in chat. And if you wanna, we'll have public reports, but also if any of you are interested in serving as, not as members, but sort of, we have a broad network of folks who are consultants and who are experts. Please reach out to me. I'd be happy to do that. Okay, Val Gunnarsson has a question. Can the PowerPoint be sent to us? Oh, thank you so much for your kind comments, Val. I think Jay can answer that. The recording will be posted, and so you will see the slides in the recording. Yes, and also I have, I could send references and such where I pulled pieces from different papers, but this is all peer-reviewed work that's been in public domain.
We had a question, Tetyana, are you seeing any indications that the softer data points are getting introduced into big data surveys?
Am I seeing any indication that these softer data points, I wish, is that question from you, Jay, or somebody, just so I can kind of, can somebody?
It's from somebody in our survey here, or in our group.
Does the person want to unmute? I have a safe environment here. I want to make sure I'm answering your question well.
Hello, this is Greg DeMarco. I was just wondering, with your observational work, getting at those points that surveys tend not to reveal, is that going to help influence future surveys, maybe getting at more of those intangibles and make them more visible for the hope of change?
Yeah, thank you. That's very helpful. So just so I could think through your question, unfortunately, I don't know that I have a positive answer to that because, obviously I don't have input on how the surveys are designed. But what I think I can do with this work, one, I think it's showing that the big data, and we're constantly investing in big data, and it is important. big data only goes so far, right? Like, remember in those differences I showed, quite a lot of it was due to facility factors, right? They matter. But then there are these things that are left, and that gets at people's relationships. How are they treated? How do they feel staff treat them? You know, they're not set, they feel that the food, they can't eat the food. Like some people talked about going hungry. They have zero engagement with others from their community. The activities are kind of developed for an 80-year-old white woman with dementia, when you have people there who are in their 60s, man with serious mental illness. And so that, of course, they're not going to be satisfied with that standard programming. So I think the question is, how do we start including those data? How do we bring it into more visible spaces? Because right now you can only do it by being in a facility. And I'd love to hear from you if you have any suggestions as well. I intend to share this work. You're one of the first groups in Minnesota I'm sharing this with. I certainly, will share this work with DHS, and I'm open to any suggestions, but it just shows the limitations in big data. It only can get so much, right?
Thank you.
Yeah. Do you see any other questions, Jay, in chat? We still have about 10 minutes here.
So amazing, this work. Here at the Pillars, we offer student housing in our building of senior living residents. So we have 10 college students that are living here amongst our residents. And it is amazing to see what a difference. So we had started that program here end of August. What a difference in the quality of life these residents have after introducing themselves to that diversity of college students. So
I love
we're
it.
seeing this work live.
Yes.
Yes.
As I said, I spent 2 years living in the facility myself. It was called the Bridge Program. For some of you who may be interested, we've published about it. And the program was actually developed not by researchers, maybe not a surprise for you, but by an administrator of a long-term care facility who saw a story in a paper about how medical students have to spend a week. Medical students in Texas had to spend like a week doing visits to a nursing home. So at least they could kind of have some exposure. And he thought, well, what if we partnered? We have this, dual doctorate program, the only one in the nation. And I was the first participant in this program. And it was life-changing. I became close friends with residents. My husband is from Minnesota, so my wedding was in rural Minnesota. This was in 2005, and we had a bus of residents driven by the administrator who drove 14, 15 hours and spent a night to come to my wedding. And so I truly think this is an opportunity for, don't just think that the residents are benefiting, the students are going to benefit greatly, because it just changes you as a person. And so I'm so happy to hear you doing that program. Oh, I see Jasmine has a question. And the question is, have you noticed any racism towards staff, leading towards staff of color leaving the long-term care profession? Thank you for the presentation. Thank you so much, Jasmine. Yes, and this is what I kind of talked about as an unexpected finding. My work, pretty much all of my work focuses on residents, so resident is the starting point. I also do work, as you noted, I'm doing work on assisted living report card. I have a big grant that's focusing on home and community-based services. I'm happy to talk about it in the future if folks are interested. But in this work, I came in looking for resident relationship, resident outcomes. And on that issue of racial slurs, it was really interesting how it seemed much more like commonplace to hear slurs for Black staff, in particular African staff. And when I talked to them about it and I asked in interviews, they said, well, some of them said, yeah, I knew that this would come with a job. But then they also talked about just the wear that kind of environment has on them. So even though I didn't have anybody, when I was doing the study specifically saying, oh, they're leaving the facility because of racism, they certainly talked about that being like an aspect of their job that they like, okay, just get myself ready for the day. I know that may happen. And I just, get myself prepared. I was actually really, kind of humbled by the attitude of many of the staff who said, oh, some of the residents, they have dementia, they don't mean it. And so they gave a lot of passes and understandings, but they also talked about the negative impact it had on them. So I think right now, the crisis that we see was the, massive workforce shortages in long-term care. If we're not going to address diversity and equity and take it seriously, who are most of the long-term care direct care staff? People of color and women and immigrants. Then if they're going to feel hostile environment toward them, of course, they're not going to work in the setting, especially when they get paid better elsewhere. So somebody, T. Trombley, so the question is, do you think that Black preferred getting care from the community because they intuitively know that the care that they would receive would be inferior to whites. You know, there is a lot of research on sort of general preference for community care. There is a tradition and culture in many communities of color that, you know, it's stigmatized to put your loved one in a nursing home. In fact, in some of my research for this project and other projects, family members, especially African-American family members, they started their interviews by saying, I'm not a bad daughter, or I'm not a bad, you know, son. It was primarily daughters, by putting my mama in. But most of it was when their mom had dementia. You know, they have to work, they have young kids, they're not able to manage, and so they put their loved one in a nursing home. But I think there's just this cultural preference that we're going to care for our own. And that is, I think, the preference for most people too. We know nobody really wants to go to a nursing home. But when it comes to home and community-based settings, in this other work I'm doing, I mean, we see national disparities in like quality home care, right? Where quality home cares go for which zip codes, you know, the zip codes that have higher poverty, higher proportion of Black residents. So yes, probably people don't want to enter a nursing home for Black people because they know that they're going to get inferior care. And it's interesting, you know, in my research, when I was looking at residents from communities of color in primarily higher proportion minority facilities, you know, I was thinking as a sociologist, well, maybe we'll see a protective effect. If you are with other people from your cultural community, maybe we'll see higher quality of life scores than, say, for people of communities of color in white facilities. Clearly, that did not work because we saw that persons from communities of color in primarily white facilities still reported higher quality of life scores than being in a primarily minority facility. And I attribute that to what I saw: lack of resources, as I said, staffing, environment, buildings, you know, there were so many things I could name here just by being in those facilities, which was very, very disappointing. I mean, mice infestation. So I think the general environment in the end trumps the fact that there are many other people there, maybe from the same cultural community, if they're all not getting the care that they need. I'm mindful of the time. I see that we have 5 minutes left. Anne and Jay, I don't know if you have any other questions or comments, or how did you want to conclude this?
I think everyone is very excited to continue to read and follow your work. So I will send out the information that we have
and I'll send you the link for the Moving Forward Nursing Home Coalition, because we definitely want public engagement. So I'll send that to you.
Perfect. I am going to send out an email with that information, and it'll have a survey evaluation about our speaker today, and that's how you get your certificate as well. So participants, you can watch for that email here in the next couple of hours. That will be coming out. We're just so thankful for the work that you do. Again, this is sponsored by the Pillars of Prospect Park. We're here near the U of M, assisted living, memory care, and independent living, student housing as well. So we're very excited to be doing this work. We have a lot of different partnerships as well through the university. To date, we have over 20. So we bring in a lot of that college aspect. So we thank you for your work and hope you have a great day, and we'll see you all soon.
Thank you so much for hosting this, Jay and Ann, and everyone for joining. Take care.
All right.
Dr. Big Player.